Welcome back, residents. Today's explainer is a rapid-fire review focusing on the absolute highest yield staging, management, and dosimetric paradigms for testicular and penile cancers. We're going to dive right in and distill down those critical updates, the shifting treatment paradigms, and of course, the precise technical details you've got to know for both the clinic and the boards.
Here's our quick organ-by-organ syllabus for today. We'll cover testicular staging updates, managing Stage 1 seminoma, Stage 2A seminoma radiotherapy, penile cancer staging updates, nodal evaluation, and finally, radiotherapy and penile conservation.
All right, let's hit Section 1, Testicular Cancer Staging Updates.
So let's look at what actually constitutes a higher-risk primary tumor now, because there's been a real paradigm shift with the AJCC 8th edition. First up, pure seminoma T1 is now split into T1A, which is under 3 centimeters, and T1B, which is 3 centimeters or greater. But here's the massive conceptual shift you need to remember: retestis invasion. Historically, heavily weighted. Now, it literally drops out as an upstaging factor. It won't bump your T stage anymore. On the flip side, if you see hilar soft tissue or epididymal invasion, you are immediately looking at T2 disease. Oh, and watch out for this curveball. Discontinuous spermatic cord involvement via vascular thrombus is actually classified as PM1.
Real quick before we move on to management, let's just make sure our terminology is locked in. The 8th edition formally adopted GCNIS, that's germ cell neoplasia in situ, as the new standard name for carcinoma in situ in the testis. So when you see GCNIS, just know that's your TIS classification.
Moving right along to Section 2, Managing Stage I Seminoma.
Now, this is a fascinating evolution. The landscape of managing Stage 1 pure seminoma has really shifted. On one hand, we had these historical risk-adapted approaches, like the one from the Spanish germ cell cancer group. They'd look at risk factors like tumor size and basically give carboplatin to the high-risk guys and put the low-risk ones on surveillance. But contrast that with what the NCCN says today. The NCCN strongly prefers universal active surveillance for all Stage 1 seminomas right after an orchiectomy. And why is that? Well, we're talking about young men here, right? We absolutely want to minimize the long-term toxicities from adjuvant chemo or radiotherapy unless it's completely unavoidable.
And here's the kicker. Just look at that huge number right there, 100%. While patients on active surveillance do face a 15 to 20% risk of relapse at 5 years, their 3-year overall and cause-specific survival is practically 100%. The safety net is just that strong, because our salvage therapies for the guys who do relapse are exceptionally effective.
Okay, Section 3, Stage 2A seminoma radiotherapy.
All right, residents, this is the technical meat of our explainer. You have got to know these landmark-based field borders cold. So for a Stage 2A pure seminoma, you're usually treating the para-aortic and ipsilateral iliac nodes to 30 gray in a Phase 1 plan, using what we call a modified dogleg field. Let's walk through it together. Superiorly, you're at the bottom of the T10 or T11 vertebral body. Inferiorly, the top of the acetabulum. Now, the lower pelvic borders are where it gets tricky. Medially, you want to draw a line from the tip of the contralateral L5 transverse process right down to the medial border of the ipsilateral obturator foramen. And laterally, go from the tip of the ipsilateral L5 transverse process down to the supralateral acetabulum. Make sure you lock those landmarks in.
But, knowing your borders is only half the battle, right? Protecting normal tissue is the other half. Here's a super high-yield clinical pearl for your renal dose constraints. If your patient has bilateral functional kidneys, your D50% has got to be less than or equal to 8 gray. But if they only have a single functional kidney, you have to be way stricter. That D15% must be less than or equal to 20 gray. Just keep in mind, if you've got medially situated kidneys, throwing in some small renal blocks near T12 can literally be a lifesaver for hitting those metrics.
And this brilliantly illustrates why our technique matters so much for these young survivors. When you include those pelvic or iliac nodes in your field, that remaining testicle is getting hit with internal and external scatter dose. Without a scrotal shield, it's taking about 4 centigrade per fraction. But with a scrotal shield, the clamshell, that dose drops down to about 1.5 centigrade per fraction. You absolutely must use that clamshell shield. It drastically cuts down that scatter dose, and it's basically non-negotiable for preserving your patient's future fertility.
Switching gears now to our second organ system, Section 4, Penile Cancer Staging Updates.
Notice how this new penile T-stage almost acts like head and neck cancer staging. It's heavily focused on anatomic depth and high-risk pathologic features. T1 is now stratified into T1A and T1B, and that's entirely based on perineural invasion, lymphovascular invasion, and tumor grade. Plus, T2 and T3 are now strictly anatomically defined. T2 means invasion into the corpus spongiosum, while T3 means it's gone deeper, into the corpora cavernosa.
Section 5. Nodal Evaluation in Penile Cancer.
Listen, inguinal node status is undeniably the single most important prognostic factor in invasive penile cancer. Even in patients who are clinically node negative, occult micrometastases are still hiding there in about 20 to 25% of cases. Historically, catching those was tough. But today, dynamic sentinel lymph node biopsy, or DSNB, is a total game changer. Thanks to modern serial sectioning and staining, DSNB boasts an incredibly low 2 to 11% false negative rate. That is huge because it gives us highly reliable staging while sparing these guys the brutal morbidity of a full inguinal lymphadenectomy.
But to use DSNB effectively, you've got to know who actually qualifies. If a patient is clinically node negative, you must look at that primary tumor pathology. Finding any of these aggressive features mandates that you offer an inguinal lymph node dissection or DSNB. We're talking the presence of lymphovascular invasion, a primary tumor that's PT1 grade 3 or higher, literally any T2 or higher disease regardless of grade, or a histology that's more than 50% poorly differentiated. Don't miss those triggers in the clinic.
And finally, Section 6, Radiotherapy and Penile Conservation.
I want you to firmly plant these dose escalation criteria in your minds. When you're doing adjuvant postoperative radiotherapy for penile cancer, your standard dose for completely resected, non-bulky positive nodes is 45 to 50.4 gray. Simple enough, right? But actually, scratch that if you run into extracapsular extension, gross residual nodal disease, or a positive margin at the primary site. The standard dose just won't cut it. Those aggressive features demand a serious dose escalation, pushing you up to 65 to 70 gray to guarantee local regional control.
Now, take a look at this data. Notice that massive jump in local failure rates when you compare tumors under 4 centimeters to those over 4 centimeters? Tumors larger than 4 centimeters fail locally over 50% of the time with conservation therapy alone. No way we can accept that. This perfectly illustrates why the ideal candidates for penile conservation therapy are strictly those with T1 or T2 disease that's smaller than 4 centimeters and clinically node negative. Pushing those boundaries is just asking for a local failure.
So, what does this all mean? Well, it brings us to the ultimate balancing act in GU Oncology. As you review these staging rules and dosimetric constraints we've talked about today, I want to leave you with this question to chew on. How do we continuously maximize organ and function preservation for these men without ever compromising their oncologic control? It's like a giant puzzle, and the answer lies entirely in what we've covered: meticulous staging, really rigorous patient selection, and technically precise radiotherapy. Thank you so much for joining me for this explainer. Keep these principles front of mind in the clinic, and I'll see you in the next one.